Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through pulmonary pharmacology, and we're going to start with some basic pathophysiology, some basic physiology, and we're definitely going to start with oxygen. So let's start there. Oxygen is a prescription medication. It's certainly fair game for your test and for the NCLEX. It comes in multiple different routes. Now, obviously, all of these are going to be inhaled route, but multiple delivery options, which include nasal cannula, face mask, non-rebreather, etc. Room air oxygen, meaning what I am breathing right now, what the oxygen that's in the air in the room that I'm breathing is 21%. So 21% of the air that I bring into my body is oxygen, is O2, versus the other roughly 79% is nitrogen and maybe a little bit of some other gases. So again, that's very important to understand. 21% of what we breathe into our body is oxygen, and then roughly 79% is going to be nitrogen and other gases. An easy way to think about it is 1/5 of the air we bring into our lungs is oxygen. Now, let me ask you a question. What is the purpose of giving a patient supplemental oxygen? When I put a patient on nasal cannula, when I put them on a non-breather, what am I trying to do? And don't say just to help them breathe better or to make their oxygen level go up. Here's what we're actually doing. When we breathe air with every breath we take, and I'll put some numbers to this that will make it make more sense to you. When we breathe air into our body, an average adult breathes roughly 500 cc's, cubic centimeters, roughly 500 cc's of air into our body with every breath. So we're breathing in all of this air, but we're really just getting that one little bit, 20% of it, 21%, that's oxygen. Bringing in all this air into our body just for this one little bit of oxygen. But that's what we have to do. That's what our environment is. And thankfully, we can all survive doing that. The problem becomes when someone is gasping for air, when someone's having respiratory distress or respiratory failure. Today, we're going to talk a lot about asthma. Someone's struggling to breathe. They can't be bringing in all this air into their body and putting in that massive amount of work to take such a big breath when really all they needed was this little bit. The problem is if they only took a little breath, then they're really only getting that one tiny little bit, 20% of that, 1/5. So what's the problem? The problem is under normal circumstances, we take this big breath of air for one little bit of oxygen. That's very inefficient, but it's fine. We can handle that. We've been doing it since the second we were born. A patient that's struggling to breathe can't do that. They can't be using all this effort to breathe in this huge amount of air just for this little bit of oxygen. So the benefit we have when we give a patient oxygen is we tell them, you don't need to bring in this huge amount of air just to get this little bit of oxygen. If you just breathe in this little bit of air, I'm going to make all of it oxygen. So you don't need to use this huge amount of effort. That's the benefit we give a patient when we're giving them supplemental oxygen. We're taking away that need to take a huge breath, and most of it, 80% of it, is for nothing just to get that little bit of oxygen. We're saying you could take a smaller breath, but I'm going to make sure all of that's oxygen. So I'm going to make your breathing much more efficient so you don't need to overexert yourself when you're already under distress. That's the purpose of giving a patient oxygen. Hopefully you understood that. So now let's go through some different numbers. A nasal cannula will roughly increase a patient's FiO2 by about 4%. FiO2 is how much of the air they're breathing is oxygen. Remember, right now we're breathing 21%, and with each liter we give them via nasal cannula, we're bumping it up. So if I put a patient on 3 liters nasal cannula, 3 times 4 is 12, 12 plus the 21%, that patient is now breathing roughly 33% oxygen as opposed to all of us. We're breathing 21% oxygen. A BVM, the bag valve mask that you guys learned about in CPR, hopefully, and a non-rebreather mask can get the patient up to about 90 to 100% of what they're breathing is oxygen. So again, if a patient is trying to bring oxygen into their body, but they're really struggling to breathe, if every drop of air that they breathe is oxygen with a non-rebreather, then they don't need to breathe in as much air when they're struggling to breathe in. Every drop of air is a struggle. Nasal cannula should always be set at 1 to 6 liters per minute. Non-rebreather should always be set at 10 to 15. A bag valve mask should always be set at 10 to 15 liters per minute. Let's talk for a minute about hyperoxia. Hyperoxia is where a patient is given too much oxygen. It's where the patient has a normal pulse ox, and yet we're still giving them oxygen. This really shouldn't be happening. We used to do this all the time. We used to say, let's say, for example, patients having a heart attack. Well, they're having a heart attack. Their heart's not getting enough oxygen. Let's give them oxygen. That makes no sense because we know that the pathology of a heart attack is not helped by giving a patient supplemental oxygen. So we don't do that anymore, especially since we learned that too much oxygen is a problem. Too much oxygen results in something called oxygen toxicity. Oxygen toxicity is where a patient has too many O2 molecules in their body. The O2 molecules break off into O and O, and now we have oxide molecules, and oxide molecules are harmful. I'm sure you've heard of antioxidants. Vitamin E is a well-known antioxidant. Patients take antioxidant because of the harmful effects of oxide. If we give a patient too much O2, we're going to end up that they're going to have a high oxide level, which is damaging to the body. So we don't want to do that. Also, and I wouldn't stress too much about this, but just the FYI, if you see this on an exam, if we give a patient oxygen when they have hypoxic drive, now most of us, where our body stimulates us to breathe when our CO2 level gets high. Remember, there's two purposes of breathing. We breathe for one purpose in order to bring oxygen into our body. We breathe for a second purpose in order to exhale carbon dioxide, CO2. Most of us, the natural way we're born is that our body stimulates us to take a breath when our CO2 level gets too high, not when our oxygen level gets too low. And again, I don't want to get too lost in the weeds here, but when a patient is under hypoxic drive, meaning that they don't have normal physiology, they don't have like the rest of us that we breathe when our CO2 level gets high. If they're under hypoxic drive, meaning their drive to breathe is based on a low oxygen level, you can, in theory, knock out their drive to breathe by giving them too much oxygen. I'm not going to go any further than that into this, as long as you understand what hypoxic drive is. One more fact about that is that it's pretty much only in COPD patients. And the whole reason behind it, just so you know, is that all of us breathe when our CO2 level gets high, but COPD patients, their CO2 level is always high. So the body sort of switches mechanisms, and it switches, instead of breathing when your CO2 level is high, it breathes when you need oxygen. And when you give that patient supplemental oxygen, you can, in theory, over a period of time, days or hours sometimes, you can, in theory, knock out their respiratory drive. We're not going to worry too much about that. You're not going to see that much of that on an NCLEX style test. That would be more at the APRN or MD level. Next, last point, we do not give oxygen to a patient that has a normal pulse ox level unless there's a specific reason to do so. Like I said, if they have a normal pulse ox level, unless it's something like carbon monoxide poisoning where we can't trust the pulse ox level. If a patient has a normal pulse ox level, what are you accomplishing by giving them oxygen? All right, finally, I want to make sure you guys understand the difference between oxygenation and ventilation. Oxygenation is the process of increasing the oxygen concentration. So when I give a patient supplemental oxygen, be a nasal cannula, non-breather, whatever it is, I am oxygenating the patient. I'm not ventilating them. They're doing their own ventilation. Because what's ventilation? Ventilation is the process of moving air in and out of the body. The patient is doing that with ventilation. Oxygenation is where I give the patient supplemental oxygen. Now, I want to clarify one point. We can ventilate a patient. It's called mechanical ventilation, meaning when we are ventilating the patient instead of them doing it by themselves. How do we do it? We could do it with a bag valve mask, or we could do it with what we traditionally call a ventilator, a mechanical ventilator, like you see commonly in an ICU. All right, now that we understand oxygen, remember this is a prescription medication. These questions are certainly fair game for any nursing school respiratory pharmacology exam. Let's move on to the first disease we're going to talk about, which is asthma, which is going to be about half of today's lecture. So asthma, let's start with the pathophysiology review. Asthma is three pathophysiologic problems. Problem number one, a normal healthy bronchi, let's say it's this wide, a normal healthy bronchi in the process of asthma becomes smaller. It becomes constricted. We have bronchoconstriction. That's problem number one. Problem number two is the vessel itself, the bronchi, becomes inflamed. So the walls of the bronchi become inflamed. Because the walls become thicker, the inside becomes even smaller. So the bronchi constricted, the inside became smaller, and now the walls became inflamed, making the inside even smaller. The third problem is the inside fills up with mucus. It's an increase in secretions. So now we have three problems. We went from a big, healthy, open bronchi, it got smaller, got inflamed, which made it even smaller, and that inside filled up with a bunch of garbage, with a bunch of mucus. You can see in the diagram here off Wikipedia that the normal healthy bronchi as opposed to a diseased bronchi with asthma. So those are the three pathophysiologic problems. As we go through the medications, you're going to notice that each of the medications tackles a different one of these three problems. And it would be very helpful if you, by the end of this lecture, you can mix and match which drug tackles bronchodilation problem, which drug tackles the inflammation problem, which drug tackles the increased secretion issue. As we go through these medications, we're going to divide them into two categories. We're going to start with the emergency medications. This is where a patient's having an acute asthma exacerbation. Right now, they're having trouble breathing because of the pathophysiology of asthma. Problem number two is the patient chronically has asthma, and we need to manage their asthma. So we're going to first start talking about the emergency treatment, and then we're going to talk about the long-term management. But before we go any further, let me break it down for you. When we have a patient who has acute asthma, we're going to treat them acutely. Now, at what point do we treat chronically? The answer there is based on the patient's symptoms. And there's a chart that you can get online. It's free. It's called the Asthma Quick Care Guide. It's published by the Department of HHS, specifically the NHLBI. And they publish the guidelines for what's considered acute asthma, or I'm sorry, what's considered stable asthma versus the different levels of progressive management of symptoms. So what do we mean really quick? When a patient has asthma, and let's say they're using their rescue inhaler once a week, perfect. We consider that controlled asthma. They're using their inhaler once a week. We don't need to put them on a daily medication just to prevent that once a week. However, if let's say a patient's using their inhaler once a day, that means every single day they're having an occurrence of respiratory distress and they're needing to use their inhaler. That is too much. That would get them put on a daily medication. What's the purpose of this daily medication? So that they don't get to that point of needing an inhaler every day. Hopefully, if they take their daily medication twice a day as prescribed, then we could get them down to maybe not even needing their inhaler at all, or just once a week or once a month even would be great. So again, we're going to at some point make a switch between managing the patient with a rescue inhaler or putting the patient on a daily preventative medication in order to prevent them from needing it so often. Where do we draw that line is really an individualized decision between the patient and the provider of what the patient considers too much. If they're using their inhaler 3 times a week and they say, I'm good with it, that's fine. They're using their inhaler 3 times a week and they say, hey, it really scares me every time. I don't want this to happen. Can you put me on a daily medication? That's fine too. So let's go ahead and start learning these medications. So the first drug we're going to deal with is obviously our rescue inhaler. It's called a SABA, S-A-B-A, short-acting beta agonist. And the drug class here is a beta-2 adrenergic agonist. In almost every textbook, you can see it called a SABA. So what are the SABAs? Albuterol and levoalbuterol. We're much more familiar with albuterol. That's what most people carry around with their little inhalers. It's Ventolin or ProAir are the brand names, and those are pretty ubiquitous. So what's the mechanism of action? They activate beta-2. What is beta-2? It bronchodilate. So it makes the lungs bigger. Remember, that was one of the 3 problems in asthma. So this is going to address that by bronchodilating to reverse the bronchoconstriction of asthma. What do we use this for? Obviously, asthma and COPD. I want to be very clear. This is used for acute only. This is used for when a patient is having an acute asthma exacerbation right now. What are the side effects of this medication? Tachycardia, hypokalemia, and hyperglycemia. Don't get those too confusing. You're going to see both of those discussed further in the fluid and electrolytes lecture, but hypokalemia and hyperglycemia, plus along with tachycardia, also comes palpitations. I will give you a heads up. This can cause some pretty dramatic tachycardia. You can have a patient that, especially if they're having a severe asthma attack, and we put them on one albuterol inhaler treatment after another, you can see their heart rate going 120, 130, 140, 150, and so on, and it can get pretty dramatic. I do want to point out one thing. If a patient has a low pulse ox and they are being treated with nebulized albuterol, leave them on their nebulized albuterol. Even if their heart rate's going up, the patient can tolerate a heart rate of 160. They can't tolerate a pulse ox of 60. Certainly chart it, certainly notify the provider, but at the end of the day, we're going to keep the patient on it because we need to open up that airway, and the body can handle a high heart rate. It cannot handle a low pulse ox. Levoalbuterol is another drug in this class. It's not as common, mainly because it's a lot more expensive, but this has less of what I just talked about. It has less of that tachycardia, less of that palpitation, so we do have benefit to it. If a patient's heart rate is starting to increase dramatically, we can switch them to this, or if they have no cardiac issues where we don't even want to try that, then we could switch them to this. This does have that beta-2 effect without that beta-1. In case you didn't remember that, beta-1 is what makes the heart beat faster, harder, stronger. This is a beta-2 drug. It makes the bronchi dilate. However, because it activates beta-2, it can also have an effect on beta-1, which is why it can have that tachycardia. Levoalbuterol doesn't really have that beta-1 effect. It focuses just on beta-2, which makes it advantageous. But because it's more expensive, we don't commonly use it. Patient education, anyone who's newly prescribed an inhaler, especially when these are children, you must educate them on how to do it. Nowadays on YouTube, you can find from almost any children's hospital a really high quality video to show your patients on how to use their inhaler. Make sure that you advocate for your patient and you make sure that the provider prescribes them enough inhalers, that they have one for their car, one for their house, one for wherever they need it. Definitely make sure that they're educated how to use it, their family, spouse, loved ones are educated on how to use it. Finally, we do also use an inhaler. Excuse me, I said that we only use this when a patient's having an acute symptom, not just preventatively. We're going to talk about that in a little bit. But when we are using it acutely, we are going to make sure, or we do have one circumstance where we use it without symptoms, and that's exercise-induced bronchospasm. EIB. EIB is exercise-induced bronchospasm, which is another way of saying that if the patient knows that their asthma flares up whenever they exercise, let's say when they go play soccer or whatever, we go ahead and we tell them to take their albuterol inhaler, usually about 30 minutes or so prior to exercise. There's variations. You'll see different textbooks. Some say 5 minutes, but at some point prior to the exercise induce or the setting that would induce their exercise-induced asthma. Next, we have, I just want to make a note, terbutaline is another drug that is technically a SABA. We don't really use this for asthma. It's a very unusual option to be used for asthma, but I did want to put this in here in case you do see that on any sort of test. Next, we have our LABA. So the SABA, short-acting beta agonist, is in contrast to the LABA, long-acting beta agonist. A LABA, a long-acting beta agonist, is going to be drugs like salmeterol and formoterol. It has the exact same mechanism of action, except this one doesn't work right away, but this one does last for longer. So when do we use this? This becomes one of those chronic medications. This is where the patient, not that I need relief for my breathing right now, but this is where I'm using my inhaler every single day. Can I take something daily? This would be one of the options. And we'll talk more about that in a little bit, but this will be one of the options to be used to treat their chronic asthma. So this is something they take every day, usually twice a day, and this would help them reduce the incidences of their asthma flaring up. Now, this medication specifically is always used in combination with another chronic medication. It is never used by itself. In fact, it has a black box warning for that. And it is given via the inhaled route. So we sort of talked about the SABA, which is our first line acute medication, obviously in addition to oxygen. Then we had LABA, we just threw in there because it's so similar, but really that was the long-term medication. Now let's get back to our acute medication. The next acute medication we have is ipratropium. The drug class here is anticholinergic. You should be familiar with this. We've seen this in the past, and we'll see this again. It's a very broad class of drugs. How does this work? So anticholinergics work in two ways. They're anticholinergic, meaning they're anti the parasympathetic or the rest and digest system. If I'm anti-rest and digest, then technically I'm pro-fight or flight. So if I'm going to activate fight or flight, that means I'm going to get my bronchodilation. So this is going to help with bronchodilation. Plus, anticholinergics also dry things up. They dry up secretions in the case of asthma. So it's going to help with 2 out of those 3 pathologies. It's going to help with the bronchoconstriction problem by bronchodilating. It's going to help with the increased secretions problem by drying up those secretions. Because it's an anticholinergic drug, it's going to have anticholinergic side effects. If you haven't seen the lecture on that already, just remember that means it dries things up. So it means you can be constipated, dry mouth, dry eyes. Remember on nursing school tests, we can ask you questions like, which of the following would be recommended for a patient taking an anticholinergic? And I might say to carry eye drops with you, to have a sucking candy to keep your mouth moist, to deal with the side effect of a dry mouth. This medication, the ipratropium, is used for acute asthma. It does come in what's called a duoneb. A duoneb is a brand name for medication. It's a combo drug of albuterol and ipratropium. So very often we will give a patient a duoneb, which is albuterol with ipratropium. Again, these are both on that acute asthma list. So we may very often give these two together. I already talked about the side effects. I do want to talk about another drug that's in this class. It's called tiotropium. Don't get this stuff confused. Tiotropium is also an anticholinergic. It also does the same thing as ipratropium, except just like the SABA and LABA, tiotropium is a long-acting drug versus the ipratropium is a short-acting. So just like with the SABA and the LABA, ipratropium is for acute asthma management, and tiotropium is known as a LAMA, and that is a chronic management drug for asthma. Moving on, we have systemic steroids. Now, I discussed this extensively in the anti-inflammatory lecture, so I'm just going to go through the quick version here. The drugs in this class are prednisone, methylprednisolone, dexamethasone, and so many more. All the steroids end in ONE, which most hormones also end in ONE. The mechanism of action of steroids we've discussed is that it suppresses inflammation. It does a bunch of other things as well. But in this case, remember we said one of the 3 problems of asthma is inflammation. So this deals with that inflammation. This is generally considered a last resort medication because we don't want to give systemic steroids when it's not needed. That being said, I want to split hairs here. We have systemic steroids as part of our guidelines for treating acute asthma, and we have it as part of chronic asthma. For acute asthma exacerbation, if someone comes in, they're struggling to breathe, we got them on the oxygen, the albuterol, the ipratropium. Very quickly, we're going to give them a systemic steroid, usually salumedrol, which is methylprednisolone. And the reason for that is because the line it says here that we give it early because it takes about an hour to work. And if I'm treating this patient for a half hour and I realize this is worse than I thought, and now I give them the shot of steroids, I'm still going to be behind the curve for another hour until this kicks in. So in acute asthma, we give it pretty quick. However, in chronic asthma, we do give this sometimes as well. We're going to talk in a few minutes about what medications we use for chronic asthma. This is one of them. And in this case of chronic asthma, then it would be a last resort option, literally last resort after we've tried everything else, all the different daily medications, but they're still having chronic severe symptoms on a daily basis. That's where we switch them or we put them on a systemic steroid. Again, there's tons of side effects of steroids. It decreases your bone density. It increases your risk of infection. It suppresses the adrenals. All of that we covered in the anti-inflammatories. If your test is going to go deep into that, then definitely go and brush up on that if you're not familiar with it. Now, again, let's switch to the chronic management. So we sort of finished up the acute management. There's going to be one left, which I'll talk about in a minute. But for acute, we have oxygen. That's going to be first line, along with albuterol, also first line. From there, we can add on ipratropium, and we can add on systemic steroids. Now let's talk about chronic management. Chronic management of asthma, like we said, is where a patient's having their symptoms too frequently or too severely. And in those cases, we start with a daily medication. The first line daily medication is going to be ICS, inhaled corticosteroids. And this would be something like fluticasone or budesonide. You've probably heard of the brand names Flovent or Pulmicor. And these, again, work just like all steroids. They suppress inflammation. Again, that's one of the three problems of asthma. We use this for long-term management. I need to be very clear. This is not for an acute asthma attack. It will do nothing for an acute asthma attack to take a dose of your inhaled steroid. Inhaled steroids take about 2 weeks to take effect, so it's not going to help an acute attack. But when we do have a patient who has chronic asthma and they're getting flare-ups more often than we like, this is an amazing drug, and it's a universal first-line drug in that case where a patient needs to go to a daily medication to reduce the amount of times they're having their asthma flare-ups. Also, when you're giving this to a patient, always educate them on how to use the inhaler because it is an inhaler. And secondly, always educate them that they must rinse their mouth out after every single dose or they will develop oral candidiasis, also known as thrush. Now we have one drug left to discuss about acute asthma, and then we're just going to keep on the chronic section, which we just started. The last one is called magnesium. Magnesium is obviously an electrolyte. It's given for hypomagnesemia, where a patient has a low mag level, but it can also be used off-label for acute asthma. And you may see this pretty much only in an ER, where we'll start an IV and put a patient on a magnesium infusion for their severe asthma. And the way magnesium works is it relaxes the smooth muscles. So again, when we talk about bronchodilation and constriction, we're actually talking about the muscles around the bronchi that control the dilation and constriction. If I give you a smooth muscle relaxer, if the muscle that's really tight around your bronchi relaxes, that means it dilates. So that'll fix the bronchoconstriction problem. So we do use it off-label for acute asthma exacerbations. There's a ton to know about magnesium. You have to continually monitor for magnesium toxicity. Most commonly, that's monitored by assessing their DTRs, their deep tent reflexes, and their respiratory rate. The major adverse effect of this drug is that if they get mag toxic, if they have too much magnesium, then their respiratory rate can drop to zero because their smooth muscles are so relaxed that the diaphragm is no longer even functioning. And we discuss magnesium further in the electrolytes lecture. Now let's continue on for the next bunch of drugs are all the chronic management drugs. So we have methylxanthines. Methylxanthines is a class of drugs that includes theophylline. Very interestingly, the most consumed drug in the world is actually in this drug class as well. I'll give you a second to get it. Too late. The drug over there is caffeine, the most consumed drug in the world, and that is actually a methylxanthine. So caffeine and theophylline are also both in the same class. That's why they both have the same suffix. The mechanism of action is that it relaxes the smooth muscle of the bronchi, causing bronchodilation. So again, this deals with that bronchoconstriction problem of asthma. What do we use this for? We use this for long-term management of asthma. This isn't one of our first-line drugs. This would be, and we'll talk more in a minute about what exactly we get into. But again, ICS is the only universal first-line agent. Everything else would be in addition to that or instead of that if that wasn't working or wasn't working well enough. This drug has a narrow therapeutic index. Hopefully you remember from day one of pharmacology, any drug that has a narrow therapeutic index has a high risk of toxicity, also requires frequent lab monitoring. Because this drug has all the same effects of caffeine, this drug can cause insomnia, shouldn't be taken by night. This drug can cause jitteriness and increase energy. It can cause tachycardia and palpitations and high blood pressure, all the same effects of caffeine that I'm guessing all of you as nursing students are probably familiar with. The side effects are again listed here. Do note that seizures is one of the big ones that we would definitely want to look out for in terms of the adverse effects. Because it's the same thing as caffeine, we definitely want to educate patients that if they are taking theophylline, they definitely can't be hooked on their big espresso every day because that can cause a problem. This is an oral medication, so that is advantageous that it's easier to take for some patients versus an inhaled medication. Finally, in case you're thinking that I'll just treat my asthma with caffeine, definitely not. Moving on. We have our LTRAs, or leukotriene receptor antagonists, and the drugs over here are montelukast or zafirlukast. And these drugs work by reducing inflammation specifically in the airways. So what do we use this for? Again, chronic management of asthma and COPD. These drugs do have a black box warning that it can cause neuropsychiatric issues. So definitely be careful giving this to a patient that has a history of depression, anxiety, or anything like that. And this is another one of those oral medications. You may recognize montelukast because this is also a prescription medication we use very often for allergies. So you may have patients that take Singulair for their allergies or for their asthma. It is used for both. Next, we have our mast cell stabilizer. That's Promelin. Again, this is the last one on our list of chronic medications that we use for long-term management of asthma. The drug in this class is Promelin. This is also, this one needs to be taken 4 times a day, which is a big disadvantage because we all learned in day 1 of pharmacology that the more times a patient has to take a medication, the lower the compliance. So we definitely don't prefer it just for that. And again, this is another one of those backup options that we have for the long-term management of asthma. And this one deals with the inflammation that is caused by asthma. Switching gears a little bit, we have the next drug class, which are monoclonal antibodies. You may have learned about these already if you watched the musculoskeletal lecture. And this one, we have one over here, omalizumab. Again, this is the drug class that has over 100 different medications in it, and it's used for everything from COVID-19 to certain bleeding disorders or bleeding overdoses. This medication works specifically with trigger-induced asthma. If the patient has severe asthma, it's because of a specific trigger that we know that it's just a histamine release that is causing that, then we can give this medication to the patient to reduce the effects of that trigger on this patient's asthma. You really don't have to know it more than there. And if I lost you there, don't worry about it. I don't think you get too far into that. Just know this is for allergy-induced asthma, trigger-induced asthma. That's what this is used for. It has a black box warning that can cause anaphylaxis. If you remember monoclonal antibodies, these are very expensive. These take several weeks to several months to work. These are almost always by injection. These medications lower your immune system. All those things that we learned about monoclonal antibodies applies over here as well. Before we move on from asthma, let's just wrap it up with a few quick notes. There are a bunch of combination drugs that we use. In fact, we use these very commonly. If you've heard of Advair or Breo or Symbicort, all of those are combination drugs. Most of those are a LABA and an ICS, as you can see listed here. I wouldn't expect you to get tested on that in nursing school, but definitely as a future nurse, definitely be familiar with those drugs and recognize that those are an ICS and a LABA. Moving on, I did put this chart in here. It is a little bit dated, but it is still current actually, even though it's from 2007, at least as of my research. And what is this? This is showing us how we in real life play out what medication a patient is going to be on. So you'll see step 1, they're on a SABA PRN. That's that albuterol inhaler. If they get their attacks every so often, once or twice a week, whatever, then they're on that. If whatever if they're on a SABA and they're still getting their attacks more often than they are comfortable with, or them and the provider together have said is too much, we switch them to a daily preventative medication. That's where we start with the ICS as our first line agent. From there, we move on. From there, if let's say that's not enough, we can either bump up the dose of the ICS or add on a LABA. Moving on to the next one, whichever one we didn't do, either now we add on the LABA or now we bump up the dose for the ICS. And we could keep moving up and up this step scale. So step number 5 would be now we're at the top dose ICS, still along with that LABA. And finally, like I mentioned a few minutes ago, step 6, the last step, is where we just cannot control their asthma symptoms. It's chronic, it's daily, it's terrible. That's where we may have to put down long-term steroids. And you'll see at the bottom of each of these boxes, we do have those other options, such as the montelukast, the Promelin, things like that to consider. Again, this is really more so NP level, or MD level, but if you wanted to look at this, I did include that in here. So let's switch gears now and wrap up respiratory by talking about over-the-counter medications, specifically for cold, allergy, and flu. So we have the primary mediators of allergies is histamine, which causes inflammation. Second thing, the common cold is caused by a virus and is treated with over-the-counter and supportive care. So let me not just read it, let me explain it. When we talk about, let's say, a person having rhinitis, rhinitis is the medical terminology for runny nose. When a patient has that, it's generally one of two things. It's either allergies or it's a virus like the common cold. And I want you to understand that because if it's a virus that's causing it, then the virus has to run its course. We may tell them to take cold and flu medication that'll help with it. However, if it's going to be allergies, then definitely they need to take an allergy medication, especially since that can be seasonal and last for weeks or months or indefinitely. So that's a little bit about what causes allergic reactions, rhinitis, and that it could be allergies or a virus. So let's talk about the first class of drugs we have here. This is the third time we've seen it. We've seen IV steroids, we've seen inhaled steroids, and now we have intranasal steroids. Intranasal steroids, fluticasone, triamcinolone. Both of these are intranasal steroids that are available. Again, we beat steroids to death already. That's an anti-inflammatory drug to deal with the inflammation that is caused by the virus or by histamine. The Flonase, specifically fluticasone, is considered the most effective over-the-counter medication for the treatment of allergic rhinitis, meaning runny nose due to allergies. Moving on, we have our antihistamines. Now, I want to be very clear. In most textbooks, you won't see these referred to as antihistamines because these are histamine 1 receptor blockers. There's also histamine 2 receptor blockers. And histamine 2 receptor blockers do something completely different, and we're going to learn about that in GI. That's for GERD. However, over here, we're talking histamine 1 receptor blockers. And since technically both of them are all antihistamines, we really don't like to use that term, and you won't find it very often in textbooks. So let's talk about this class of drugs. They're pretty big class, pretty common. Most of it's over the counter. We have our diphenhydramine and doxylamine. That's Benadryl and Unisom. Both of those are over the counter. We also have hydroxyzine, and that's a prescription-only antihistamine. Again, histamine 1 receptor antagonist or histamine 1 receptor blocker, or to keep it short, H1RA. How do these work? These block inflammation by blocking histamine. It says it in the name, so that's simple to understand. The indications for these drugs. So let's start to make this a touch confusing. I broke this list down of these 6 drugs into first half and second half. The first half are known as first generation, and yes, this is something you have to know. It's definitely in every nursing textbook I've seen. There's the first generation antihistamines and the second generation. The first generation ones are the diphenhydramine, doxylamine, and hydroxyzine. Let's talk about those first. What are those used for? They're used for allergies. They're used for insomnia. They can be used for EPS. They can also be used for, I didn't put it on here, but they can be used for some of the symptoms of Parkinson's disease. They can be used for anxiety, and they can be used for nausea. Some of those are off-label, some of them are labeled. But it has a whole bunch of different uses. What are the side effects? Again, I'm talking the first generation, the top 3 on this list. The first generation drugs are used for, have a side effect of drowsiness, and also some of the anticholinergic effects, like the dry mouth, dry eyes, etc. Again, those are all fair game for your test, so please make sure you recognize that if something's anticholinergic, that means it can cause constipation. Because it can cause constipation, that means you need to educate your patient, increase fiber, increase fluid, increase activity. All of these things, don't just expect an easy question like what drug has anticholinergic effects. Expect it to be more complicated, like what drug would require you to educate a patient to carry a sucking candy with them. And you have to recognize that that's dry mouth. You have to recognize that's anticholinergic. You have to recognize what drug that is. So those are the first gen. Let's move on to second gen. That's loratadine, fexfenadine, and citrazine. You're probably familiar with these medications. They're all over the counter. Claritin, Allegra, Zyrtec, they're all advertised on commercial all day long. And these have one indication, and that's for allergies. These have pretty much no side effects, and these are all the second generation. Moving on, we have our nasal decongestants. This is going to be oxymetazoline, pseudoephedrine, phenylephrine. Again, these are generally over-the-counter medications. So how do these work? The mechanism of action is they stimulate alpha receptors. Alpha-1, if you've already learned this, or if you remember this from A&P, alpha-1 causes vasoconstriction. So this is going to target the blood vessels in your nose and cause that local vasoconstriction of the blood vessels in your nose, and that causes reduced inflammation. Reduced inflammation resolves or at least improves your symptoms. What do we use this for? We use it for nasal congestion. And an adverse effect of this is that it can cause restlessness. It can cause a little bit of fidgetiness, a little bit of being antsy. Intranasal is the most common route that we use for this, and this is considered a more targeted route than giving it PO. Patient education is that this class of drugs can cause rebound symptoms if they take it for long-term, and long-term in this case really is about 3 to 5 days. If they're taking their pseudoephedrine or something like that for more than 3 to 5 days, they can end up with their symptoms coming right back as soon as they stop taking it. Next, we have our antitussives. Now, there's really going to be, depending on your textbook, what's going to be considered an antitussive. I'm going to start with dextromethorphan. Dextromethorphan, which is over-the-counter, that's Delsym or Robitussin, and these decrease the sensitivity of your cough receptors, thereby reducing your cough. If your cough receptors are very sensitive, it's making you cough all the time. If it's less sensitive, if this decreases the sensitivity, you won't be coughing as much. Now, what do we use this for? We use this to reduce coughing, very simply. And I'll talk in just a minute about some side effects of this. Now, you may also see in your textbook antitussives, including codeine. I'm going to talk about codeine separately because that's why I've seen it in most textbooks, but you may see it this way as well. Let's move on for a second, then we'll get back to codeine. We have a drug class called expectorants. That's going to be guaifenesin, and that's over-the-counter Mucinex. This works by increasing the effectiveness of your coughing. So obviously, if you have a cough, let's say bronchitis, the body's trying to get rid of something. This helps your body have more effective coughs so that you don't have to cough as much. Now, I want to make a point here, very importantly, specifically for Mucinex and Robitussin and Delsym. I'm pretty sure every one of these makes their medication with their competitor's medication. So Mucinex has Mucinex DM, which includes Delsym or Robitussin, not actually the drug, but the drug name, but the ingredient. So guaifenesin, which is Mucinex, can be found, if you look at the back label, with dextromethorphan. And dextromethorphan can be found with guaifenesin. Be very careful with these medications because you run the risk of, if you want a patient to be taking both and the patient's taking Mucinex DM and Robitussin, maybe it's called Plus or something, and now they're taking actually both ingredients twice because they didn't realize that each one had the other one. So just be very careful with that. Also, just a general note, a lot of these medications can cause a patient to have adverse cardiac effects like tachycardia or things like that. So just in general, be careful with recommending over-the-counter medication. In general, as an RN, you're almost always safe to do that. But if a patient starts to have underlying, especially cardiac conditions, stay away from that. Let the provider make the recommendation, even if just an over-the-counter option. Now let's talk about codeine. Again, some textbooks may include this under the antitussives. Codeine is obviously an opioid. It's a controlled substance, just like morphine. This also used to suppress the cough. And dextromethorphan that we just talked about, which is Delsym and Robitussin, also is very structurally similar to this, to the point that a patient can technically get high on dextromethorphan if they take enough of it, which is one of the reasons a lot of pharmacies keep that locked up. The side effects of codeine, obviously, it's an opioid, CNS depression, constipation, nausea, hypotension. Like all opioids, it has a black box warning for risk of abuse and dependency, and also respiratory depression. This is obviously by prescription only. This is obviously a controlled substance. Because it has that issue of CNS depression, anything that has a concern for CNS depression cannot be taken with alcohol or any other CNS depressant. Finally, like we're almost done here, benzonatate is known as Tessalon Pearls. That's a prescription-only medication. And most of you are probably familiar with cough drops, like Hall's cough drops that patients suck on, and as the medication dissolves, it numbs up the throat, which numbs up the coughing sensors. This does the same thing, but it does it orally in a pill. So you take a pill, and this does the same thing. It numbs up those cough receptors. You don't get that feeling in your mouth that you get when the whole thing feels numb from a cough drop, but this does have the same net effect. What do we use this for? We use it for a cough. The good thing about this medication is that it's very safe to take. It doesn't really have any side effects. The bad thing about this is it doesn't really work as well as some of the other medications. For patients that work for it, it's great. Lastly, we have the mucolytics. The drug over here is acetylcysteine, and this thins out your mucus. It decreases the viscosity of your mucus and makes it very thin and more easy for the body to cough up and get rid of. That's why it's called a mucolytic. N-acetylcysteine is in the same drug class, but this is used for an acetaminophen overdose. We talked about that when we talked about analgesics. And then lastly, I've seen this in a bunch of test banks. This medication does have a very bad odor, which is a normal thing for this medication. So I've seen that as a test question. What should you do if you open this medication that has a really bad smell? Nothing. That's appropriate in this case. If you have any questions, please let me know. Please subscribe to our channel, and please have a great day.